Hey, Dr. Demke, how's it going? So, I'm doing a presentation and a review of facial anatomy for my 2 week anatomy review class. So, we'll start with the orbital anatomy. So, we'll go over some superficial features of the eye. It's fairly like self-explanatory and visible. Um, you have your medial angle, you have a lateral angle. Also, you have the lateral palpebral commissure, that's the corner. You got your lacrimal carbuncle, which is that little gooky, gumpy thing in the middle. You have eyelashes and cilia. You have a superior and inferior sulcuses. It's not labeled here, but you got your epicanthal folds. Um, and this is mostly your cosmetic regions of the eye. Cosmetic's not the right word. Just the superficial landmarks. So below this, you have fat pads. These are super important for like blepharoplasties and removing, trying to make a younger look or pulling the eyes in to improve, or the eyelids in to improve visibility. Superiorly, you have two, the nasal and the preaponeurotic ones. That's medial and lateral. And then below, you have the medial fat pad, middle, and lateral. I just think of it as a triangle, three on the bottom, two on the top. And like I said, those are super important. You would clip into those. You have two approaches. I've seen two approaches done often for the bottom ones especially, which is like pulling the eyelid down and then going internally to take out the fat, or cutting externally and taking out the fat. I think the big difference is are they having reduction of the skin? If you're reducing skin on the bottom, then you just take it from the front. But if you're not reducing skin on the bottom, you're just trying to bring down that puffiness, then I've seen people go internally into there. The arteries of the eye. So the arteries of the eye is great. Lots of arteries, lots of places that get covered here by a lot of collateral branches. A little bit complicated, probably more detailed even than what I did here. But coming off of the angular artery, which is a branch of the facial, which comes off the external carotid, you have your lateral palpebral artery. That'll give you your superior and inferior palpebral arteries. The angular artery and the infraorbital actually, branch out into, you'll get a lateral palpebral artery. The collateral in, you have branches from the temporal artery and transverse facial all linking in. And the supraorbital artery, supraorbital and supratrochlear and infraorbital are all coming off of your internal carotid, up your ophthalmic artery. So you have collaterals from all over the place. Internal carotid, external carotid, multiple arteries. It's just a big arcade around there. The muscles, so you have your orbicularis oculi, there's orbital parts and palpebral parts. You also have your frontalis and your procerus. The frontalis is your big forehead, and your procerus is kind of right there in the middle. These are all superficial. If you're doing some sort of like skull or cranium work and you fold it over, if you see a muscle, you're likely to see the corrugators because they're deep. I've done some cosmetic procedures where you cut those to. That's the Botox target. So if you're there, you can cut them, and then they don't have to worry about that. The levator palpebrae is deep internally, so it helps lift your eyelid. It's not really visualized here. Your motor branches for the eye come from your temporal and zygomatic branches. The zygomatic is your orbicularis oculi. Basically, that's the main target of it. But your temporal branches also hits a little bit there, but it hits everything else too. Sensory nerves, you have mostly it's V1 and V2. So your ophthalmic cranial nerve 5-1 will give you your lacrimal, supraorbital, supratrochlear, and infratrochlear. So you can see lacrimal, supraorbital, infratrochlear, supratrochlear, infratrochlear. You have external nasi over here, but that's different. And then you have your infraorbital, zygomaticofacial, and zygomaticotemporal. These wrap the eye around. Questions. I have to do 3 questions. So, a 74-year-old female is having trouble opening her eyes sufficiently. It is interfering with her ability to drive or to perform her other activities of daily living. What should be considered and offered to her? A blepharoplasty to remove excess skin from the upper eyelid and reduce the superior 2 flat pads. glasses, ophthalmology, consult, and reassurance this is normal. Well, none of these are bad. She might need glasses, and she might need ophtho, and she's definitely aging. The blef would be something to actually relieve her visual symptoms. The nose, here are your surface landmarks of the nose. There's 9 of them, 3 paired and 3 unpaired. So you have the sidewall, the nasal ala, and the soft tissue facet, and you have the columella, nasotip, and the nasal dorsum. Sidewall, nasal ala, and soft tissue facet are all mirrored on the other side. Arteries of the nose, mostly coming off of the angular artery, which is off of the facial. So you have your... you do have the anterior ethmoid, which is up here. This guy comes off of your ophthalmic, which is where all this eye stuff came from that we were talking about. But your angular is going to be in here, and it'll give you your dorsal nasal, lateral nasal, superior alar, inferior alar, and your columnar right down in here. Nasal cartilage and bones. This is, again, really important for recons and cosmetics. So the names here get a little confusing because there's multiple. So you have your upper lateral, or just lateral is the big guy up here. Your nasal septocartilage is the one that you often take down for like a hump takedown. You have the lateral crus. So this is your lower lateral major alar is another name for it. You have your minor alar on the sides. So this is the lateral crus and the medial crus of your lower lateral or your major alar. Crus is like limb. The nasal septocartilage is down there. You can see it from a different angle. And then your nasal bones are up top. Sensory nerves of the nose, it's going to be V1 and V2. So you're going to have your infratrochlear, external nasi, and infraorbital. Give you your nose. Muscles around the nose, you have a nasalis, which kind of wraps around it. And then you have your, down here is the depressor septi, so this kind of pulls a little bit on the nose. And then you have your levator labii superialis aliquinasi. This runs along the limbs down to, along the nose down to the lips. So question, a high school basketball player took a pitch to the face and appears to have damaged his nose. In addition to checking for fractures, why is it important to check inside the nares of the septum to identify if there's a septal hematoma? So, 1, to make sure it doesn't bleed out. 2, a septal hematoma can lead to reabsorption of the cartilage septum, resulting in a saddle nose deformity. 3, check for airway obstruction. Or 4, a good physician should always do a good thorough exam. In this one, if you have a septal hematoma, you can end up resorbing your cartilage in the nose. If you get that saddle nose deformity. Oh, sorry about that. The ear. Lots of landmarks here. Oh, we'll get to the arteries first. Arteries. So coming off of the auricular, anterior auricular and posterior auricular is where everything mostly comes from. And then your anterior is going to give you a superior, middle, and inferior, and your posterior comes behind. Seeing the superior kind of wraps around like this. That's very important for blood supply, and it can cause, like, if you have a trauma or something, especially like right down here, if you lose that posterior, you might end up losing higher up due to ischemia. Sensory nerves, very complicated, the sensory nervous system is for the ear. So you have your C5, cranial nerve 5V3, so your mandibular branches send off auricular temporal. That's going to be your upper third, I would say. Cranial nerve 10 hits your external canal and right there in the concha. The lesser occipital is off of your cervical spine, C2, C3, and your greater auricular is also off of C2, C3. It's going to give you more down here. This is a lot of places for nerves to come from, so if you're working here, you might have to just circumferentially numb out everything to get good anesthesia. Landmarks anatomy. Your helix, your helical rim there. You have the antihelix. Here's your helical crus. Here's your antihelical crura. They have a triangle fossa in between those crura. Darwin's tubercle. Scapha, the little ship boat thingy, like a scaphe, right? That's sitting in there. Antitragus and your tragus. Again, anti's on the inside, opposite tragus and helix on the outside. Lobule, it's the only spot without like the elastic cartilage. It's really floppy. And then the concha. You have your the Kaimba, I think is how you say it, concha, incisura. Incisura is where it's cutting in there, right? Cartilage is all elastic cartilage, except for the lobule. The mouth. So landmark, you have your upper vermilion border. This is kind of the spot between mucosa and skin. You have your philtrum ridges with the philtrum. This isn't marked here, but you have Cupid's bow up on the top. You have your upper lip, lower lip. You have your mentolabial sulcus. You have your commissures right and left, and the oral fissures. The muscles, so many muscles of the mouth. We have a lot of speaking and facial expressions done by it. So you have your levator labii superioris, you have your zygomaticus major and zygomaticus minor. Those all give you lifting. Rhizorius opens wide. You have a levator anguli sits under the levator labii, so that's going to pull that angle up. You have a lot of smile muscles up here. Zygomaticus major and minor, again, pulling up at those angles. So you have like 1, 2, 3, 4, kind of 5, all pulling up in your smile. Orbicularis oris wraps around here. Rhizorius goes on the sides, but superficial pulls you. The depressor anguli, this is going to pull down. And the depressor labii is also going to pull down more laterally, and this one pulls out more medially. You have a masseter, which is a chewer. You have a buccinator, which is the cheek muscle, sits over there. You have a mentalis and platasma. Mentalis is more of a chin thing, kind of crumples your chin, and then platasma is neck. Arteries, it's actually much more simple than like the eye. With all these muscles, I thought it'd be more complicated. But you have your facial, which gives you your angular. Your angular gives you inferior alar, which will give you the septals that come down. And then off of the angular, kind of near the angular fascia junction, you also have your labial artery that gives you superior. You have superior and inferior labial arteries that just wrap around. Nerves, buccal branches and the marginal mandibular branches are giving you that. Again, this is all cranial nerve 7. Platasma is cervical branches, but that's not mouth. Sensory nerves of your mouth, you're going to see cranial nerve 5, maxillary and mandibular. So you're going to, the infraorbital is going to do your upper lip, and then you're going to get your, mental and buccal branches of your mandibular are going to give you more the lower and lateral lip. Another question. 4-month-old boy is being operated for repair of a cleft lip. What are the layers that need to be reconstructed individually when putting a lip together? So you have skin, muscle mucosa, skin vascular mucosa, skin muscle vessels, muscles mucosa. So skin muscle mucosa is the right 3 layers that you need to make sure you individually respect them all and get them all correctly aligned. And that is my presentation. I appreciate you taking time to look at it. Thanks.